Welcome. Today we're going to talk about Strengthen Opioid Misuse Prevention, the North Carolina STOP Act. My colleague, Dr. John Spangler, and I will be dividing the lecture up into two parts. The objectives include a brief discussion of opioid use disorder and some North Carolina statistics. We'll describe the North Carolina Prescription Monitoring Program, PMP Aware. We'll review the STOP Act and then discuss case scenarios with an emphasis on opioid avoidance and identify situation of patient issues with harm reduction strategies. Dr. John Spangler and I, Julienne K. Kirk, have no relevant financial relationships with commercial interests pertaining to the content presented in this program. Opioid use disorder is defined as a problematic pattern of opioid use that leads to serious impairment or distress. We're going to abbreviate this as OUD. In 2016, over 1,200 North Carolinians died from opioid overdose, an over 20% increase from 2015, and those numbers continue to rise in 2019. EMS reversed an opioid overdose using Naloxone more than 13,000 times in 2016. Now we have Naloxone readily available at all pharmacies without a prescription. In 2015, North Carolina providers wrote a large amount of opioid prescriptions per 86.8 per 100 persons, 8.7 million prescriptions. The average U.S. rate was 70 opioid prescriptions per 100 persons. So North Carolina is above the national average. When we look at opioid abuse, North Carolina has 4 cities in the top 20: Wilmington, Hickory, Jacksonville, and Fayetteville. Opioid abusers are more likely to live in the rural South, and you can see the highlighted areas on this map of which North Carolina has a predominance. If we look at North Carolina Emergency Department visits for opioid overdose about a year ago, this was a staggering increase from the previous March 2017, 457 opioid overdose compared to 371. These counts are based on ICD-9 codes, 10 codes, depending on where we extract the data from, and can include any intent, accidental, intentional, assault, or those that are undetermined. We have cases to include poisonings with opium, heroin, opioids, methadone, and other synthetic narcotics. When we look at other data, the rate of opioid overdose by county is also impressive. The demographics of 2018 opioid overdose compared to 2016 North Carolina standard population census is also impressive. You can see that it can affect any age group, but there's a strong predominance in those of 25 to 34 age range, and it affects a larger portion of whites compared to other ethnic groups. North Carolina Opioid Action Plan has several focus areas to create a coordinated infrastructure. We have to reduce oversupply of prescription opioids, and this is going to take a reduction in diversion and flow of illicit drugs. Without increased community awareness and participation for prevention, we won't get to our projected numbers to decrease a total goal of a 20% reduction. We need to make naloxone widely available. Any patient getting large amounts of opioids above a 50 morphine milligram equivalent needs to have a naloxone prescription that a significant other or family member is taught how to use. We need to expand treatment and recovery-oriented systems of care, and then measure our impact and revise strategies based on the results. The North Carolina Prescription Monitoring Program, known as the PMP Aware, is a prescription monitoring solution that provides state government agencies with accurate real-time data compliant with regulations. With the PMP Aware, the end user, prescribers, and dispensers can make better informed decisions and potentially intervene earlier with accurate data. North Carolina joins Prescription Monitoring Program InterConnect to help address the opioid epidemic. So our current controlled substance reporting system, the North Carolina CSRS, is now interwoven into this PMP Aware system to provide multi-state information regarding opioid prescriptions, as well as additional patient history where appropriate. To register for the North Carolina PMP Aware, I've included how to log in there. You register, you got to give some specific information about yourself and your license number. And I've copied down the menu at the bottom of the page where you can see a dashboard, patient request. When you do a RX search, you're going to have to definitely set up your user profile. And it's very unique in the fact that all you need is the patient's birth date and name. And once you load that patient into the system, it will bring it back up when you go and query information on that same patient again. I would include everybody and encourage you to look at some of the training. They're brief slide decks that are very informative. So for example, Narx Score. What is that? It's a weighted combination of variables that include drug equivalents, number of providers, potentiating drugs, number of pharmacies, and overlapping prescription days. The score is intended to create a composite risk index which increases as the value of one or more of the risk factors in any given prescription drug monitoring program increases. So many states are using this. It puts things on a level playing field that you can assess risk. And it's derived from a population study of over 5 million patients. So Narx scores exist for 3 different drug types: narcotics, sedatives, and stimulants. There's a score that ranges from 3-digit 0 to 999, and it represents a relative scoring system of controlled substance usage. You'll get an average, and then the last digit is actually the number of active opioid or prescription drugs, depending on what category you're in. So there's a calculation to determine the weighted average of all the scaled values. Half of the weighted scales is allocated to the morphine milligram equivalent, and the rest together equal the other half. Go and review the videos. It's informative, and I think can help you organize and assess patients for risk. Let's move on and talk about the STOP Act, Strengthen Opioid Misuse Prevention. This law is aimed at curbing misuse and abuse of opioids in North Carolina and was passed unanimously by both houses of the General Assembly June 28, 2017, signed by Governor Roy Cooper. The STOP Act targets controlled substances under the Act, Schedule 2 and 3 opioids. I've given you examples of these: codeine, morphine, oxycodone, hydrocodone, fentanyl, methadone, etc. It doesn't include stimulants such as methylphenidate or other medications used to treat ADHD. I've also provided a website for you there. The key STOP Act provisions are quantity limits that will be required on initial prescriptions for targeted Schedule 2-3 opioids that we just reviewed. 5-day supply for acute pain, 7-day supply for post-op pain with no free refills. Additional fills may be authorized pending determination of need. with the physician or advanced practice provider. North Carolina Medicaid's opioid safety policy is also a document that we need to talk about. Medicaid revised the policy to better align with the Centers for Disease Control's guidelines for prescribing opioids for chronic pain. Strategies in the North Carolina Opioid Action Plan are aimed at reducing the oversupply of prescription opioids available for diversion and misuse. Prior approval will be required for opioid analgesics, including tramadol. Medicaid also requires that anything exceeding 90 milligrams of a morphine milligram equivalent per day will need a prior authorization, and that there's a non-preferred opioid products list that require a prior authorization. Pharmacies are required to report prescriptions to the North Carolina Controlled Substance Reporting System that interlinks with the PMP Aware, and it has to be done and delivered within 24 hours, where previously there was a 3-day window. Schedules 3 and 4 opioids are subject to the same opioid coverage criteria as Schedule 2 opioids. Here is a source of North Carolina Medicaid opioid safety resources that would be useful and available at the website that I've created below, and includes frequently asked questions on naloxone standing orders, the STOP Act that we've already talked about, the preferred drug list, some non-opioid pain management alternatives, the conversion and morphine milligram equivalent, and then general provider and pharmacy information, along with tapering of opioids with provider considerations in going through with those steps, which can be a long process with patients, but a necessary one. Here is a list of the short-acting opioids with an overview of some of the criteria in a comprehensive chart here to specifically look at an update as of June 2018 on the different areas. There are some exemptions, as well as length of the prior authorization at 6 months. The exemption would include a patient with cancer. And then some of the criteria for long-acting opioids. Maximum day dose not to exceed 90 morphine milliequivalents. And again, some of the information where a prior authorization is required. The North Carolina Tracks portal is also a useful website. It's a multi-payer Medicaid management information system for North Carolina Department of Health and Human Services. The prescribing provider may submit prior authorization requests to NC Tracks through the portal. New opioid analgesic prior authorization forms and revised clinical coverage criteria are available on the North Carolina Tracks PA Medications webpage. And beneficiaries with the diagnosis of pain secondary to cancer will continue to be exempt from PA requirements. This will end part 1 of our discussion. I appreciate you listening today, and part 2 will include case examples. Thank you for listening, and have a good day.